first recorded use of any alteration in atmospheric pressure for medical purposes was by the British physician Henshaw. Henshaw believed that certain chronic diseases might respond to reductions in pressure: scurvy, arthritis, rickets. Conversely, some acute conditions he thought might benefit from a raised atmospheric pressure. Now, the year is 1662 and the world has yet to discover oxygen, so we're merely talking about just hyperbaric, the use of pressure as a therapy. It's doubtful that Henshaw really met with much success, and more than 100 years would pass before another attempt was made to use pressure therapeutically. After all, Priestley did not discover oxygen until 1775. Although historically important, this gas was not used for yet another 160 years. Largely attributed to Lavoisier in 1789, who suggested that oxygen, although perhaps therapeutically useful, might have a dark side. In 1830, Junod introduced the concept of hyperbaric spas, and he commenced to treat patients who had pulmonary disease with 2 to 4 ATA of pressure. Now, there's a term that's probably new to you. ATA, what is that? Well, it stands for atmospheres absolute. We're going to learn more about pressure and this concept of ATAs later, but for here, understand that 1 ATA is sea level, so 2 would be twice sea level pressure. So at least you have a working understanding. Now, with Junod's enthusiastic reports, there was a widespread interest throughout continental Europe with these hyperbaric spas. And of course, when we look at the physiology, you'll come to better appreciate why an increase in pressure might help people with pulmonary disease. In 1870, Fontaine introduced the pressurized OR and noticed that patients would recover more quickly from the anesthesia of the day, nitrous oxide. Now, if you know something about nitrous oxide anesthesia, then the use of pressure and gas volumes to rapidly displace and wash out the nitrous oxide would physiologically make sense. It was Paul Bert who in 1878 confirmed what Lavoisier had feared, that indeed oxygen does have a dark side, and he demonstrated the presence of oxygen seizures when breathing high concentrations of oxygen under pressure. We'll look at this concept of oxygen toxicity a little later in the curriculum. In fact, we have an entire hour dedicated to looking at this concept of oxygen toxicity. Haldane in 1895 demonstrated what was to become the first therapeutic indication for hyperbaric oxygen. He demonstrated that a mouse containing what would otherwise be a fatal exposure to carbon monoxide could survive that if the balance of the gas was oxygen under pressure. In 1928, a Professor Cunningham noted that people affected with the Spanish flu had a much higher mortality when they were at a higher altitude than those patients who were near sea level. Now, if any of you have been out to Denver, Colorado, the mile-high city, and had to run out to your car, you probably noticed you didn't get very far without becoming short of breath. This is a reflection that at 5,280 feet above sea level, the mile-high city, the pressure of oxygen is greatly reduced compared to sea level pressure. Again, we'll look at that physiology in greater detail in a couple of sections from now, but understand that Cunningham noticed this, and he began to reflect on the fact that oxygen under pressure could be very useful. And he happened to treat a particular individual, a Mr. Timken. Timken was an industrialist who had made a significant fortune, happened to be suffering from a case of renal failure, was treated by Cunningham, and just coincidentally got better. Now, hyperbaric therapy had very little to do with this improvement, but it was a fortuitous coincidence because Timken commissioned the construction of a massive hyperbaric hospital, as you see here in this illustration. This was an enormous engineering feat. This is not just a hyperbaric chamber, this is a hyperbaric building. Dr. Cunningham treated a wide variety of diseases, diabetes, hypertension, syphilis, and cancer, which he believed had an anaerobic etiology. Now, due to a lack of controlled studies and persistent failure to report data, he was ultimately censored by the American Medical Association. The hospital was closed in 1930, and this marvelous engineering feat ultimately disappeared from the landscape in the 1940s. Because during the 1940s, the United States was engaged in World War II, and steel was far too precious a commodity to leave in a field in Ohio. So the entire structure was consumed and turned into battleships and tanks. Now, there are lessons to be learned here from Cunningham's ball. As a great historical philosopher, Santayana once said, "Those who do not learn from history are doomed to repeat it." And you know, every year there are physicians who have the best of intentions treating patients who may have heart attacks, strokes, conditions that physiologically might make sense, but clinically we have yet to establish a firm database. And these well-intentioned sort of excursions into hyperbaric therapy are no different than Cunningham's. I'm sure Cunningham also operated with the best of intentions, but a failure to proceed under a organized, rigorous IRB, Institutional Review Board, is not much different. So keep that in mind as you move through this curriculum. I would encourage your excitement, certainly encourage in clinical investigations, but for these investigations to be meaningful, they must be controlled in at least some fashion, and they must also be done in accordance with the human protection of subjects under an IRB's watchful eye. In 1937, we begin the oxygen era, because it wasn't until the 1930s and into the 1940s that oxygen was actually available in sufficient quantities for routine use. You know, we take it for granted today that when that giant tractor trailer pulls up, hauling that cryogenic container with liquid oxygen, that it's always been in abundance, plentiful, and easily obtainable. But you know, that hasn't been the case. For example, the bulk delivery of oxygen was really not available until the 1960s. It was the space race and the National Aeronautics Space Administration that really pushed the development of cryogenic insulators that allowed us to begin the bulk transport of liquid oxygen. Prior to that, in the 1930s and 1940s, simply the extraction of this gas from the air in itself was a fairly difficult feat, and the amount that could be moved around in these heavy steel containers in a gaseous form was really quite small compared to what we move now with the liquid oxygen reservoirs that we have. In any event, 1937 is when oxygen began to be applied to hyperbaric therapy. And then we can really begin to characterize this as hyperbaric oxygen therapy, because it was in this year that Benke and Shaw demonstrated that the use of oxygen in the management of decompression sickness produced a striking improvement in results. Now, we'll talk about decompression sickness in greater detail later. But in the early 1930s, people understood that when divers or construction workers had been working under pressure and you decompress, they would develop a mysterious illness. And they call this decompression sickness. It has sometimes gone under other names like Caisson's disease for tunnel workers or the bends. In any event, it was well recognized that the use of recompression or pressure would help to cure this disease for many individuals. What had not been noticed is the addition of oxygen with pressure produced a striking improvement and a much higher success rate. So many authorities would consider the 1930s and the specific year of 1937 to really be the milestone that began the oxygen era of hyperbaric therapy. Now, decompression illness today still remains perhaps the only illness that can be treated simply with pressure. And in very mild cases, there are treatment tables that simply utilize pressure. But as we know, thanks to the pioneering work of Benke and Shaw, the addition of oxygen produces a marked improvement in the results. 1955 was also an important year. In that year, a cardiothoracic surgeon, Dr. Boerema, wrote an infamous paper entitled Life Without Blood. Dr. Boerema had a particular interest in congenital heart disease. Now, the year is 1955, and the world has yet to discover cardiopulmonary bypass. Boerema, operating on these very young children with cyanotic congenital heart disease, was in the proverbial rock and the hard place. The surgery necessary for these children oftentimes was life-saving, but performing it without cardiopulmonary bypass incurred substantial risk, and oftentimes the procedure became life-taking. So Boerema thought, what if I was to do this procedure utilizing oxygen under pressure? I might be able to buy precious time to complete a very complex procedure. Now, before he engaged in this bold experiment, he decided to sit down and mathematically look at the physiology. And we're going to do that in the section on physiology. Look at the exact calculations that Boerema considered. And the mathematics suggested that life without blood might be possible. But of course, he had one important step, and that was to demonstrate what appeared to be correct on paper, in fact, was achievable. So what he did is he took pigs, did an exchange transfusion against Ringer's lactate and dextran, rapidly lowering their hemoglobin down to a fraction of 1 gram of hemoglobin. And as you'll see here in a minute, these pigs ran happily about the hyperbaric chamber with no untoward effect, despite the near virtual absence of hemoglobin, red cells, from their bloodstreams. So we're going to take a look at this video, and you are a select and privileged group to actually see the infamous Boerema pigs.
An experiment, in fact, shows that life without blood is possible under hyperbaric conditions. Pigs breathing pure oxygen at 3 eta are totally exsanguinated. The volume of fluid in their circulatory system is maintained. The absence of erythrocytes makes the pig look very pale, but the oxygen supply is adequate. After reinfusion with their own blood, the pig lived happily ever after.
That is amazing. Well, let's continue on our timeline here. In 1955, Churchill and Davidson introduces the clear-walled acrylic chamber. Now, many people new to hyperbaric therapy believe the genesis of the clear-walled acrylic chamber was driven by the need to produce an environment that was less confining. As you'll learn later, confinement anxiety, also referred to as claustrophobia, is a common problem in everyday clinical practice. We'll talk more about that later, another piece of the jigsaw puzzle. But what really drove the design parameters for this clear-walled acrylic chamber was their interest in combining hyperbaric oxygen with radiation to perhaps improve the cure and the kill of cancers. Now, those of you that manage cancer patients know that a hypoxic tumor is notoriously difficult to treat. The hypoxia confers a certain resistance on tumors. You know, radiation kills cancer through several different pathways. One pathway is a direct hit on the nucleus. But when you consider the size of a cell, that nucleus is really a pretty small target. So most of the radiation just streams through, not striking any critical structures. But this radiation can also cause irreparable damage if the cell is hyperoxygenated, because now when the radiation comes through, it will leave behind it, like a comet's tail, a stream of superoxide radicals, and these will ultimately cause the death of the cancer. So hyperoxygenating a cell certainly has a great deal of clinical merit as a strategy. In terms of what Churchill and Davidson found, they found that the tumors actually shrank faster, there were fewer metastases, but unfortunately there was not any significant difference in survival. However, there has recently been papers coming out of Japan that indicate that the use of HBO for glioblastoma multiforme stage 4 might be beneficial. These authors looked at the combination of simultaneous radiation with hyperbaric therapy in this difficult disease. This is a malignant cancer of the central nervous system typically found in children. Children with that advanced form, stage 4, typically have a 1-year mortality of about 80%. When HBO was combined with radiation, what they discovered is the 1-year survival now was 80%. They had actually taken night and turned it into day. That study, by the way, is now being replicated here in the United States under an NIH grant, and we anxiously await to see the results. And it could be that Churchill and Davidson had the right idea, they were simply applying it to the wrong tissue. Because the central nervous system is a very fast tissue and considerably different than the kinds of cancers that would populate the head and neck region. And that's precisely what Churchill and Davidson was treating. Cancers in this region are typically squamous cell carcinomas, and biologically, they're very different. Now, the development of these clear-walled acrylic chambers certainly have gone a long ways to making it easier for patients who have concerns about tight spaces. The next significant milestone on our review occurred in 1961. In that year, Dr. Brummelkamp published papers indicating that HBO was very useful in treating anaerobic infections. His first paper detailed its use for clostridial gangrene, and we'll talk more about that when we talk about the therapeutic indication of anaerobic infections. This paper was appearing almost in tandem with Borma's earlier work, and it was these two publications that really sparked a great deal of international interest in the therapeutic potential of oxygen under pressure.